I am pleased to introduce today's speakers. Michael Trangle is a mainly retired board-certified psychiatrist who is a lifetime distinguished fellow of the American Psychiatric Association. He is a past president of the Minnesota Psychiatric Society, was executive medical director for behavioral health at Allina, and senior medical director for behavioral health at Health Partners. Currently, he is a senior fellow at Health Partners Institute for Research and Education. He co-chairs the National Quality Forum's Behavioral Health Committee and is a vice chair of the Minnesota Governor's Mental Health Advisory Council. Clinically, he has 36 years experience treating adolescents, adults, and families, both inpatient and as outpatient. Beth Silverwater is a mental health education conference planning committee member. She's a patient, a community volunteer, and an activist on mental health issues. So I welcome you to begin.
Could we change the slide? All right. So what I think is reasonable for any of you to expect if you're seeing a psychiatrist really are the following things here. That whatever psychiatrist you see should listen to you very carefully and look at you while you're talking. That individual should be competent, should be respectful, compassionate, and should be working off the idea that you're there, while you're there, you're keeping and doing whatever you can to ensure that the interests of your patient are being served. You want to be reliable, you want to be available, which we could talk about more what that means later. I don't think it generally means taking a call at 3 and 4 in the morning 4 or 5 days a week, but it means being responsive in a timely way and having a system around you to make sure that there are people responsible whenever you need it, even if it's not that individual. You should try to use whatever scales and ways to sort of like measure things so that you can do the best practice, which is kind of an evidence-based practice based upon how you're actually doing and getting beyond just subjective answers to questions such as, I'm fine, I have no problems. It needs to be more granular. And if you could switch to the next slide. Okay, you want to really be partnering with your patients, and you need to be kind of listening to them, their thoughts, their feelings, their values, their priorities, and factor that into whatever you're doing, whether it's psychotherapy, whether it's medication management, whether it's a decision about levels of care and whether someone needs intensive therapy or a partial hospital or a hospitalization. You want to be partnering with other caregivers so that it's a united team in working with the patient. And you want to and need to respect confidentiality while at the same time preserving safety. So Beth, do you want to comment from a patient's point of view about what you expect from a psychiatrist?
Well, I have a few things about expectations of a doctor, a psychiatrist. One, under being competent, you can check the credentials and information like education and board certifications online. There are also some websites that have evaluations of the potential doctors by patients. Just do an internet search on the doctor's name. Also, you may find information on websites of medical groups like Health Partners and Allina. The handout that you can access later is called Talking with Your Doctor, and it has a whole section on selecting a good doctor. I also wanted to say, as far as being compassionate and respectful, the patient wants a doctor that listens, has a warm manner, and is respectful of you. he or she should treat you with dignity, compassion, and respect at all times. Also, as far as being reliable and available, available means it should not be hard to schedule an appointment to see them. With urgent issues, you want to be able to speak with either the nurse or doctor. And for routine matters like scheduling appointments and prescription refills, they typically go through a scheduler, receptionist, or nurse. As far as your relationship, it should be one of a partnership where treatment decisions are discussed together and treatment suggested should be agreeable to both parties. The doctor should talk with you about the diagnosis and what treatments he or she thinks would be best for you. He or she should also discuss with you how the diagnosis and will likely cause you to acknowledge that you have a new normal in life. The patient and doctor should discuss the risks versus benefits of the treatment, and the patient needs to determine if the treatments proposed are congruent with their values. And then as far as medication, the doctor should relay why they are prescribing the medication, the dosage instructions, and whether it should be taken with food or not, potential side effects. If you have severe side effects, contact the doctor. And if you have life-threatening side effects, which are very, very rare, go to the emergency room. Also, how long will it take for the medication to have an effect? How long do I have to take the medication? And also, what is your practice's system for getting refills? Please note that many mental health problems are due to a chemical imbalance. It is biologically driven. It is not a weakness. These illnesses are like diabetes and epilepsy. You need medication to fix the imbalance. And one other thing I want to mention as far as treatments, hospitalization is not a bad thing. It can be very helpful. I've gone through inpatient care, day treatment, and partial hospitalization. And they were very helpful in reducing my acute strong emotions and suicidal feelings. Also ask if there are any good websites about diagnosis or medications. And again, see the talking with your doctor as far as getting reliable information from the internet. And that is it for my comments on that.
You know, let me just add one or two things that I could have said, but now that you talked, it reminds me of them.
Okay.
If you know yourself, some people are great to just show up and their thoughts tend to be organized and they can kind of rattle off what they want to say first, second, and third. Other people kind of get flustered at times and it's not so easy. And if you know kind of what your style is, and you're someone that might be flustered, you might want to write down your questions ahead of time. And you might even want to sort of, this is the big things I really want to get answered. And if there's time allowing, we could go on to these other things. But for some people, it helps to even just write it down and make sure they're organized. You know, once in a while, someone says, I'm just so anxious or so mistrustful, or I just don't hear things. I want my best friend to come with me, or so-and-so to come with me, and that should be okay, you know, generally. Whatever aids you might think of to help you function as well as possible so that you can hear and speak as clearly and optimally, not that it has to be perfect. I would say go for it.
Okay, can you please change the slide to the next one? Thank you. As far as expectations of a patient, show up on time. It should go without saying. It shows you really respect the doctor and his or her efforts to help you. I usually get to an appointment 15 minutes ahead of time so that I could check in, fill out any appointments, any forms that need to be filled out, and have a chance to relax myself before the visit. Very, very helpful. Also, you should dress neatly. It will make you feel better about yourself, and it will show the doctor that you are serious about the visit and respectful of the doctor's time and help. You should bring a list of all medications, both prescription, over-the-counter, nutritional supplements, and natural compound supplements that you take each day, along with the strength of each pill, the dosage instructions, and also include medications that you take on an as-needed basis. Mention if you are experiencing any side effects with your medication. Also, your doctor or pharmacist can check for conflicts with your medication. Next thing I want to mention is be open and honest. Really, really important. Make good eye contact. It shows that you are believable and shows your interest in the appointment. Be open to different treatment types than you may have had previously. Speak assertively, not aggressively. Be concise and to the point. Use I statements, i.e., I feel, it feels, it seems to me, I need, I appreciate. There is a handout. There's a handout on ways to speak assertively, not aggressively. Also, when you're explaining and being open and honest, it's important to express your feelings, both mental feelings and body sensations. And in your handouts, there is a list of feelings and body sensations that you can look at after the presentation. Okay. You should also share your impressions of the visit by saying, I feel, say if you felt comfortable or rushed, ask for clarifications if you need for the doctor's instructions. Don't cry wolf or you will not be taken seriously. Really, really important. And remember, feeling is neither right or wrong. They just are. And it's your job as a patient to view them to the doctor, to relay them to the doctor. Be organized by writing down and prioritizing in advance a list of the most important things you want to relate to your doctor, and Dr. Trang will address that. Be concise and brief. The appointment time is limited. Take notes during your appointment. See the handout that I just showed you about feelings and body sensations to help you express yourself more clearly. And we've also included a handout called, it's basically on how to start a mood journal. And there are also apps on there are also I said as far as creating a mood journal, many apps for your phone and tablet that can help with you also. Speak up about issues you might have. Be assertive, not aggressive. Again, I showed you the handout. Give observations and descriptions, not opinions and judgment. Be concise and to the point. Give information, not instructions. You can disagree, but clearly identify concerns from your own perspective. You can bring a family member with you or a friend, like Dr. Michael Tringle had just said. My husband came to some of my appointments to support me, to substantiate some of the symptoms I said I was having, and to reinforce this with examples of some incidents. And be mindful and respectful of the time. We will address time management in just a little bit. Pay bills on time. That way the doctors will be paid for their visits with you. Other things, you have the right to a second opinion. They can be very helpful. In my case, the second doctor's diagnosis and treatment were in line with my regular doctor. You have the right to change doctors, but there may be some limitations depending upon your insurance policy or HMO. Also, if you prescribe glasses or hearing aids, wear them. You really want to be able to see and hear well during your appointment. If the doctor is speaking too quickly for you, ask him or her to speak slower. Don't approach your doctors outside the office in their off time. It is their time off. If you think you might socialize in some of the same social circles that they do, ask the doctor to establish at an appointment what they want you to do. Now, I'll give you an example. I was at a Costco with a previous psychiatrist, not Dr. Tringle, who was pacing back and forth and seemed very angry, like frustrated, I should say. I went up to him and said, "What are you looking for?" And he said, "Bananas." And they were on the table right behind him. I pointed that out. I said hi, and then I left. During the next appointment, he started screaming at me for having disrupted his free time. And you need to understand and establish at an appointment what the doctor wants you to do if you run into them in some other situation outside of the office. I also can't emphasize the importance of being open and honest. Dr. Tringle was a previous psychiatrist. I saw him for about 17 years. He's wonderful. And I had a situation where I was very suicidal, and I said I held a knife up to my neck. And I came in and said this, that I was suicidal and I had done that. And Dr. Tringle asked to see my neck to see if I had broken skin. At first, I was confused and angry, but Dr. Tringle wanted to properly assess the severity of the situation so he could make the appropriate measures to be taken. Dr. Tringle, do you want to discuss how you make decisions in times of crisis or emergency?
Sure. So, I mean, the example you gave was a real life example, and it's really pretty, whether it's a knife to the neck or some other kind of suicidal type of thing, or I'm rageful at somebody else. I mean, it's in some sense, that's why we're around, to deal with situations like that. It's, how do I want to say this exactly? Ideally, it would be great if you could do several things all at once, but it doesn't tend to play out that way. I tend to just say one thing at a time, and I don't say two things simultaneously. So on the one hand, as a psychiatrist, you want to express, this is an important thing, and I want to be empathic for what you're saying and where you're coming from and have an understanding of it. At the same time, I need to be technical and figure out concretely how dangerous this is. And to some extent, I'm trying to think about what is the next step of what I need to do to keep you safe, and that could range from if someone is truly dangerous, and it's not on or off, you're either dangerous or not. It's what are the odds of you trying this again? And whatever you're trying, what are the odds that that's likely to kill you versus not likely to kill you? So somebody said, I'm holding a gun and I did Russian roulette and I had one bullet in there and I pulled the trigger a couple times. That's hugely lethal, versus I've had some people say, I thought I would just stop eating and drinking and I'm going to kill myself that way, which could still kill you, but it takes a while for that to happen, and what kind of response that demands might be a bit different. And the options that I'm thinking of in terms of what needs to happen potentially to keep someone safe could range from you need to go to a locked psychiatric unit because you're actively and repeatedly trying something that easily could kill you. So you have to be someplace where someone with you 24/7 and you can't escape, and they take away lethal means and it's much harder to do it, versus let's talk about this at your next visit. It's not going to happen right away. It's not likely to be lethal, versus let's have you go to a partial hospital program or an intensive outpatient program. There are a number of different options of what we arrange. And what I need to do is basically get details about so the kinds of questions that are asked, not just looking at your neck, but if someone's talking about an overdose, what are you thinking about overdosing with? Have you obtained those things? How close have you gotten to taking? How many pills of those have you taken? What are the combinations? To find out whether it's really likely to be lethal or you hadn't gotten that far in your planning yet. And it was, you were contemplating it versus I've started doing it and I'm all ready to do it, then it can work instantly, So those are the kinds of gradations one needs to sort of think about to then think about the plan of action. And I know that when this came up with us, when I wanted to get details, I think your initial reaction, and you're talking in a very sort of cool, calm, directed, fashion, was really sort of feeling hurt and very angry. And I think you felt like, why is he asking me all these questions? He doesn't believe me. He doesn't trust me. Whatever it is, it doesn't feel good to me. He needs to react strongly and show me that he cares. And I don't know what your fantasy was of what I needed to do, but it really was a combination of trying to be empathic and listen and hear, but at the same time to technically do whatever I need to do to make sure you were safe. And that means gauging how close you got and then talking about the alternatives with you. So maybe you could comment on where I was coming from.
And this is something that we discussed not a little bit then and a lot more a few years later. Again, it was, a lot of it was trust, and I was still relatively new with you, so I didn't know how you would react. But I'd hoped I established enough trust to have you believe me and the fact that you asked to see my neck. At the time, I didn't understand that, and I was quite concerned. But Dr. Trangle was really straightforward in his approach. I ended up going to day treatment for several months. And I really, really appreciate your caring about my welfare. And that's really important for a doctor or psychiatrist. So thank you.
Um, and I don't want to be, how do I want to say this? I don't want this to be a lecture about what's more lethal and what's less lethal. But, but in some sense, I just vaguely said, well, I need to find out what the plans are, how far along you are in the plans, whether you've gotten all the ingredients together, and then how close you've come to acting on it. If you didn't act on it or didn't finish acting on it, what stopped you? What were some of the strengths involved with that? What were some of the anchors you had to life that might still keep you alive, and kind of figure out how to balance those things together. And it varies what those factors are for every individual, and ultimately we stepped up the intensity and frequency of what kind of treatment you got, but it was still shy and giving you more degrees of freedom and less restriction than being in a locked inpatient psych unit, and sometimes people have this idea that getting admitted to a psych unit is going to cure everything and they can do anything there. And as someone who's worked in psych units and managed psych units for decades, there are certain things you can do there and certain things you can't, and it's not even just medications, but it's sort of where you're at psychologically and what your environment is like, how safe, how stable it is, how labile it might be. If someone's in an abusive situation, there's just a lot of factors like that to factor in. And those are the kinds of situations that really test what is the relationship that exists. It can either strengthen them or it can blow it out of the water. If it feels like it blows up, this person isn't listening to me, he's not believing me, he's doubting what I'm saying, can you talk that through? And can you both stick with it to get to a point where you can each understand where the other one comes from or came from, and it sort of makes sense that there are different roles. Any comments on that?
I don't have any right now.
Okay. Do you have more to say? I want to comment on some of your patient expectations, but I would like you to finish first, probably.
I'm done.
Okay. The last one on the screen, I mentioned confidentiality, you mentioned confidentiality. I mean, to some extent, I don't know that I have an expectation that patients have to keep their own information and thoughts and feelings confidential. It's their choice whether they keep it confidential or not. The psychiatrist owes you as a patient confidentiality, but let me kind of tell you what that means to me. It means, because there are certain circumstances where I breach confidentiality. And when I first start working with somebody, I tell them that up front, that basically whatever you mean, I want you to be open and honest and share your thoughts and feelings and your fears and your hopes, that kind of stuff. And that's crucial if we're going to work together and make it useful to you. But if you're at a place where you're likely to kill yourself and I need to do something to keep you alive, then I have to breach confidentiality and do what it takes to keep you alive. In a similar way, if you're at a place where you're so rageful at somebody that you want to kill them, and and once again, it's me gauging how close that is. Is that an idle thought that you really hadn't done any planning, kind of thing? Or there's a specific individual and this is my plan and I've got this equipment to do it, whatever the means is, then I have to breach confidentiality and make sure that safety is provided. And actually, if you've named a specific individual that you want to kill and you're planning to kill it and you're going to do it, I actually have to warn that person, which is something that came from a legal case, Tarasov. In a similar way, if I'm seeing an adolescent, there are certain things that I'm seeing the adolescent, and generally I would see the adolescent, but I would also meet with the adolescent and the parents together. And in a similar way, if the adolescent is a place where they're doing something that risks their safety or somebody else's safety, I have to breach that. It also comes up if sometimes I've had patients that, and then a relative wants to see me. And that engenders discussion about what would my existing patient, does the second one that's showing up that wants to see me as well, is the first one aware of that? And talking about confidentiality, do they trust that I could keep things separate and keep my mouth shut and only breach confidentiality in certain ways? What are they hoping to get from the fact that I'm already seeing their relative? Is that to their benefit? Are they worried about that? Why me? What are the good parts about that? What are the bad parts about that? Is it worth it? Do both sides feel okay about that? It can get complicated that way. We say be open and honest, but I can't tell you how often it occurs that it seems like I'm seeing somebody and there's stuff that they're thinking about or reacting to that they're brooding about, and they're just very upset or anxious about it. Or it could be something's happened that they're just titillated and excited about, but they don't bring it up, and it comes out after the fact. And if you really trust the person you're working with, it's much better to just bring it up. They're not going to sort of judge you. They're not there to sort of say, oh, you're a moral person, or you're this. We're all human. We all have good things, and we all have things that we're ashamed about, or things that we failed at and are ashamed about. And that's part of what it is when you're a human, and that's part of the package. And to the extent that you, how do I want to say this really sort of plays out not just with psychiatrists, but with therapists as well. To the extent that you can be kind of sharing that in an honest way, those things that you're not proud of and that you feel kind of uncomfortable about, says that you're sort of developing a not sexual, but sort of a true intimate emotional relationship to talk about these things, and that you don't have to sort of try to look artificially good and hide things that you're not proud of. And it says a lot about trust, and then I think is a good sign about your ability to work through similar kinds of things with people that are really in your life, not in the artificial doctor-patient relationship. Do you want to comment on that, Beth? Or
it is, I guess I want to emphasize that it is important to understand the relationship between a doctor and patient. The doctor, is typically very empathic, very compassionate, and sometimes people confuse that with actual affectionate feelings towards the doctor. And you need to realize that is the role of the doctor is to care for you. He or she knows a lot about you, but you very rarely know much about them. So it's not like it's a balanced relationship in that sense. But you have to, again, understand that it's a doctor-patient relationship, and that's how it should be maintained.
And there are some constraints that psychiatrists have. I mean, and I guess they boil down to, as a patient is making themselves vulnerable to you and being open and honest, and the fact that it's not a symmetric, equal relationship, it means as a doc, you really need to be constrained by whatever you do has to be in the patient's best interest, and you can't take advantage of that. It's considered, and it's not okay for psychiatrists to ever get into a romantic relationship with a former patient, let alone a sexual one. And it's not okay to receive exorbitant gifts that are worth a lot of money, that kinds of stuff. there are certain constraints that that are there within the profession to prevent us taking advantage of patients who may be going through emotional reactions like you were talking about, where they have some transference and some feelings towards the doc that may not be real life based, but could still be motivating them. And we should not be taking advantage of that.
Yeah, I agree.
So Wendy, do you want to open it up to if other people have questions before we go on to the next session? The next section? I mean, they don't have to ditch us yet. I just meant section.
Right. So don't have any direct questions at this point, other than, with a telehealth visit, help you communicate. Have you used those during COVID to talk to patients or to talk to your provider? And was it beneficial?
I can tell you from a doc's point of view, as well as a system of care point of view, being able to use either televideo or even a telephone, audio only, has been a huge boon. And that we have a lot of patients, especially patients that have childcare issues, transportation issues, live in rural areas, can't get away from work, but they could potentially connect with you while they're at work during a break. Or we have patients, folks that are like seriously mentally ill and are kind of disorganized and have a hard time kind of getting in, and people that were afraid to come in because of COVID, that it was a huge boon. And we were able to reach out, and all systems of care basically found that during the pandemic, with the ability to have the ability to do either audio or televideo, we saw more patients than we did before. And we had less no-shows, less people that couldn't get in or canceled at the last minute, whether it's transportation or childcare issues. And that it was just a very big boon. And there are surveys. I'm on the board of NAMI, and NAMI recently did a survey, and people in that survey said televideo was really sort of a lifesaver for some of them. At the same time, it allowed them to connect when they otherwise wouldn't have been able to. Part of that was because it was set up that the docs and therapists would get paid the same amount if it was a televideo or a face-to-face visit. And traditionally, they weren't paid the same way. And that's going to be a huge issue going forward. And for the audio only, the telephone only, that was sort of a lifeline for people that had chemical dependency issues and were afraid to go in for treatment, people that were homeless but still had telephones, people that once again were disorganized or just rural and had transportation or childcare issues. It just made a huge lifeline for them. And in Minnesota, televideo is going to continue to be paid at par, I think. But the telephone only is supposed to sunset after 2 years. And I think it's DHS is doing a study so the legislature can talk about that again. But if any of you are listening, I think it's such a big deal and such an important issue. When it comes due the sunsetting in a year and a half from now, if you could lobby your legislators and tell them how important this is, that would be very helpful.
I just want to add a few things. Medicare is covering e-health or telehealth calls or visits, I should say. But you may also need to contact and lobby your federal legislators, congresspeople or US senators. The other thing is, I know I have personally found the telehealth video appointments very helpful. One, being scared of COVID, But number two, I live northwest of Minneapolis, and my psychiatrist is in St. Paul. It's much nicer to be able to do it over video. And I certainly hope it will continue and will stay. And also the psychologist I see, he is in the office only 1 day a week. So he does video, telehealth video visits 4 days a week. And he's hoping not to have to go back into the office more than once a week. So just letting you know that.
I have a question for you as far as, do you have suggestions, or what do you do if you're the spouse or caregiver for a patient and you want the doctor to know something that will like really make difference or make the patient upset? Is there a way to communicate to speak to the doctor without the patient present, or to alert the doctor that you'd like to speak with them alone?
From my perspective, if there are troublesome things, I have to realize that, in my case, my husband, as a caregiver, is only trying to be helpful by sharing incidents or emotions that I'm showing. Dr. Chengle, do you have any other thoughts?
Yes, I do. Probably after making a few mistakes early in my career, I've come to a point where my attitude about this is, one, I can listen to information about my patients from anyone. You know, anybody can call, write, email, or text either my team, the receptionists, the nurses, the social workers that are part of the team. And I'm willing to take in that data and factor that in and listen to anybody. And it doesn't obligate me to reveal that somebody else is my patient, let alone any facts about them. I don't have to acknowledge any of that stuff. What I'm not willing to do is to say I'm going to keep that a secret from my patient, because my relationship is with the patient. If that person might happen to be my patient, I wouldn't necessarily keep the fact that somebody reached out to share their concerns about them from them. I owe them that. I don't owe confidentiality to other people, just to my patients. In a similar way, well, I'll just leave it at that. A rare event for me. Maybe we should go on to the next section, some of the scenarios.
I think you were going to handle, start off with time management.
Okay, couple different thoughts here. During the first time somebody comes in, there's just a whole bucket load of sort of data and information that I ideally need to sort of learn reasonably soon. And during most sessions, the idea is you sort of have a kind of like a reasonably efficient conversation that's not high pressure, that's not rushed, and you kind of talk about what's going on and stuff. But during the first visit, you need to sort of get an understanding of why someone's there. You need to ask about what kind of symptoms they have had historically, what history they've had, how that kind of comes together to potentially come up with some diagnosis, what symptoms they're having now, if they were treated before, what worked, what didn't work, what caused problems, whether it was medication side effects or other problems. And I need to get a history about what's going on with them medically. I need to hear about what medications they're on, what other medical diseases they have, what's going on with their use of caffeine, which can make one anxious, alcohol or drugs, whether you exercise, whether you have adequate sleep, what's going on in your social life, Do you have a good support system? Do you have a significant other? Are there issues going either for better or worse or both with that? Are you employed? How do you feel about that? Are you financially okay? Are you desperate? Are you being abused? And I need to get a sense of what's going on with you right now, kind of go through current symptoms and things like that. And then we need to have time so that I can really hear what you want out of the visit, what you're afraid might happen, what you hope might happen, and talk about how I put that together and formulate that, and then talk about potentially how there are different treatment alternatives. And let's talk about what some of them are and figure whether we want to start something right now. And it might be you do one thing. Ideally, you don't want to do 3 things at once. And if you then have a problem, you don't know which of the 3 things is causing the problem. So where do we start and what do we consider later? All of that's very difficult to do in like a 50-minute initial hour. So it's a setup to feel rushed and pressured, and it's just not easy. So that's the intake. Then let's comment on that. Then let's talk about sort of regular visits once you've gotten to know somebody.
Okay. I want to relay an experience I had where I made a big boo-boo in following my own advice. I was seeing a psychiatrist, or I went in for an initial intake with a psychiatrist, not Dr. Trangle. And I'd written out a story that was, or my mental health history. And I talked on and on. Yes, the psychiatrist got a few questions in here and there, which I answered. And then there was like almost no time left at the end. And one of the things that needs to be addressed is what can I use to help with my sleep? And rather than it being a partnership at that time, he just dictated to me what I should take and what type of hours and when to set my alarm in the morning for it to get up. And this ended up being a real problem. First of all, in how the decisions were made. Also in that he didn't get to hear what specifically my problem was with sleep. The second visit, which was a med check visit, I briefly apologized for the way I was before, for the way I talked on and on before. And I said, this is supposed to be a partnership. We're supposed to work together to come up with treatments. And so I explained what my problem with sleep was, which was having problems going back to sleep in the middle of the night after I've gotten up or woke up, not falling asleep in the beginning, which required a different sleep aid. And I also mentioned that because of my other health problems, I needed more hours to sleep than what he thought I needed. So we talked about that, and then the normal things during a med check visit, which Dr. Trangle will go into. And then there was one thing I did do that I was thanked for, and I think it's a good suggestion. And that is during the initial intake, or for the initial intake, prepare a document that lists your major medical problems and what measures you take or what medications you take to treat those problems, so they don't have to remember everything. And the doctor was very, very thankful that I brought that list for him to take. What do you want to share, Dr. Trangle?
Before I talk about the standard med check, let's talk about how decisions are made. You alluded to that just just a little bit ago. I think theoretically, you have a continuum. One end of the continuum is you've got some autocratic doc telling the patient what to do, and this is my prescription, do it. The other end is, and I've seen some patients like this where we talk about things, we agree on a course of action, and somehow the patient never does it. They just do whatever they want, And my sense is neither extreme is good. I mean, if you're not doing sort of shared decision making where you're kind of factoring in what are the patient's priorities, what are their values, what are their fears, what are their hopes, and what are they willing to do, what terrifies them. I remember for a while people would be on Prozac and everybody was worried they'd go postal. Because I don't know who's old enough to remember those days, but that somehow people thought taking Prozac would cause a rage, as was made notorious by a postal worker, shooting up in a post office. But you sort of want to be in the middle where you talk about alternative things and what are the risks and benefits and come up with something that you agree this is a reasonable approach. Let's do it and let's manage it and make sure it's a fair trial of that. And if it doesn't work, you go to something else. I think if you're seeing someone and you're not asking them to make every decision for you, some patients really want that, especially it seems more common in folks that are kind of older and less common in people that are younger. But that's an ageism, and I probably shouldn't have said that, although cultural expectations. But I've also seen patients that really, despite all kinds of talk and agreement about stuff, they never do it. And at some point I kind of say, I'm not sure I'm of any use to you. We talk about stuff, but if you're not making any changes in your life at all, or even willing to do therapy or do any medications, why do you keep coming in, And so on rare occasions, I've sort of said, take a break, see how things go, and let's kind of reconnoiter after you've had a hiatus and just kind of see how things feel to you and how you're doing. So anyway, I do think it's if you have a dance between people and it's really shared decision making is ideal. Standard med check, most med checks are 20 minutes, some places it's 15 minutes, and it's a lot to do in 15 minutes. You really do need to get a sense of what's going on in that individual's life, how they're doing with symptoms, just how they're doing with relationships and how they're just feeling overall. At the same time, you need to hear about technical side effects and different physical medical parameters and then adjust things. And you can do it, but it sometimes feels rushed. And in many ways, I think the worst case scenario is, and it can certainly happen once the first time, but you don't want it to be a pattern, is if the patient waits till they're almost walking out the door and then they come up with sort of like a really serious dangerous thing that they only mention as they're walking out. Oh, by the way, I'm going to kill myself within the next week. See you later, which is talking about time management. And if there's one thing I could say, if there's something that really might be dangerous, or it's just, you're passionate and you're just kind of obsessed with it, do it early so we have time to talk about it, and, sometimes you flex where if somebody says that at the end, you run late and then other people are pissed off at you, your next patients and stuff, because you do what you got to do. But you certainly don't want that to be a pattern or a habit, or it needs to be addressed if that's the case. So feel free to comment on that, Beth.
I think you've done a good job. I guess the only thing I'd ask is what happens if someone is hesitant about taking meds or doesn't want to take meds? That would probably be my only question I would pose to you, actually.
I mean, I think it's okay to be hesitant. I mean, what I try and do is negotiate something. All right, you don't want to do meds. Let's do some behavioral activation, maybe in bettering your sleep or exercise or doing some positive social things. Let's come up with a plan why don't we do this for a couple months, you know, see how it works and see if your depressive symptoms get better. And if they don't, let's agree we'll try something else, like maybe a med. You know, I'm certainly willing to try alternative kinds of approaches. What doesn't seem okay to me is to sort of stay in a bad place and not try every legitimate alternative. And some of those involve meds, but not necessarily only meds or just meds, you know?
Right. That's good. Thank you.
Any audience questions, Wendy? As our time draws nigh.
Yes, as our time draws nigh, our last 3 minutes. I don't see any other questions. I did like your discussion of making that decision together about using meds or not using meds and other alternatives and how you decide what's appropriate when. Thank you for sharing that. Let's see if we have any other questions here. I've had questions about handouts. So handouts you will find on the homepage. So the conference homepage. So they're great handouts that we're trying to put those together. So please take a minute to look at those. Any last words from Dr. Trangle?
I like ladies first.
You have a minute.
I think we covered most everything. If Josie can put on the slide with our email addresses, so that if you have any questions, you can send us a note, and we'll do our best to get back with a good answer.
You know, in some sense, now that we're finishing this up, I decided I don't like our title, even though we chose it. Because when we say optimizing, you know, psychiatrist or doctor-patient communication and stuff, it's like, how do I want to say this? You need to, ideally, it could be something that's it's a week-to-week sort of thing that's not high-pressured. It doesn't have to be perfect, you know, but if you sort of like keep talking and talking it through, and if there's a mishap or somebody has hurt feelings or somebody, you know, was running late, you know, instead of saying, you know, it's all or nothing, it's perfect or awful, it's like you sort of say, well, how do we do it better in the future? And just continue to work together in a way where you learn to trust each other and realize you're both trying your best, and people make mistakes and people forget things and people overreact or underreact sometimes. But if you keep there plugging away at it with good intentions and good competency and stuff, you know, it's well worth it for patients to work with therapists and with docs. And there's a role for therapy, there's a role for medication, there's a role for other kinds of things, TMS, vagal nerve stimulation, things like that. We didn't really get into substance abuse, but it's you know, there's a whole other realm about how do you work that through, what's the role of the family or the employer when somebody's sort of not being able to see it and they're blind. But we're not going to talk about that today, but all those same things apply on that realm.
Thank you. Thank you both, to Dr. Trangle and Beth Superwater, for sharing your insights. It's been very helpful.